Well, good evening, and welcome. I want to thank you so much for joining me tonight on the late one this Sunday evening, Sunday the 3rd of the 11th, 2024. And I want to thank those who are joining me on Instagram, those joining me on Facebook, YouTube, and TikTok on the Overflow. But of course, when I say TikTok, I always say TikTok. What you need to do, you need to jump over onto the YouTube, which is Silburn TV. There you can see the glorious face of the guest. You don't want to see my face, you know what I'm trying to say? You only see my face only on TikTok, you know what I'm trying to say? But you need to see the glorious face of the guest, Dr. David Burton, tonight. Well, ladies and gentlemen, tonight I'll be very quick. Tonight is one of those nights where we have these sort of sit down discussions, and I'll be having a discussion tonight on cataract. Uh, cataract operation. As a matter of fact, I need to take off my glasses because really and truly, I mean, I got 20/20 visions now, and I'm trying to say a few years ago, I got these guys telling me that I got these things running through my eyes. I'm trying to catch them back, and I'm looking and I'm looking and I'm saying, "What's that? What's that? What's that? This thing running through my eyes." Then I learned when I went to the optician. She said, "You got cataract. I got to refer you." And I said, "Oh my days, what's that?" One was very excited about it in a sense of going to the hospital, St. Thomas Hospital, and removing the cataract in one eye. So therefore, the reading glass for the reading is needed, but for the driving, there's no need for that at the same time. But somehow you get so sort of used to wearing the glasses at the same time. But I'm going to have Dr. David Burton, without further ado, who is going to be talking about this because we said investing in your health is something. And here, so it's years back in COVID period, we used to have all these discussions on prostate and diabetes and discussing the whole aspect of taking care of yourself during the COVID period. And we think we're going to be having some more discussions on health, investing in your health. So without further ado, I'm going to bring in Dr. David Burton, and we're going to have that discussion on cataract. Hey, I can see you, David.
So that we all may see. Hi, good evening, everyone. Good evening, Silver, and thank you
Yeah.
for the introductions. Thank you for welcoming me back onto the platform. It's been a long
Yes,
time
yes, yes.
in the making, but I'm really grateful to be here to talk about something that's quite passionate for me,
Mm,
which is health, investment
yeah.
in your health, and on that topic, my background as an ophthalmologist, I really wanted to talk to listeners today about cataract. And obviously your journey as well with regards to
Yeah.
cataract you heard there in the introduction. So yeah, thank you very much for welcoming me back
Mm.
onto the platform.
No, thank you, Doctor Burton. As a matter of fact, people sometimes say you're not doctor, you're Mister. You know what I mean? You're high level or something. What is it? You're not a doctor, you're Mister, isn't it?
Yeah, so I guess in layman's terms, yes, you could say I'm a Mister, but then for some people they may not understand what that means. So
Yes, yes,
just to recap, that's somebody who's surgically trained
yes.
in this country. But if you went to other countries wider afield,
Mm.
Mister dropping the doctor title, people don't quite
Yes.
understand. So I don't mind to be referred to as Mister or Doctor this evening.
Yeah. Well, thank you for that, David. Doctor. So tell me, what is cataract? For argument's sake, because for me, I've learned a bit of it through the process, and doing the operation. But in a way, still, I've not really. I might learn. I'm going to learn a bit more about it tonight as well. But is there any preconception or so about cataract as a consultant ophthalmologist that you may say flag up the whole issue that you want to even have this discussion?
Yeah, so let's talk cataract. In terms of what a cataract is, people from all walks of life will more often than not enter the discussion in regards to cataract and the need for helpful need for removal of a cataract. Cataract in its simplest form is a clouding of the lens inside the eye. So and you'll see the slide sets that we'll bring up in a little while, but the lens inside the eye allows you to focus. Allows you to see for near. You talked about reading earlier, but it also allows you to see for distance.
Yes.
And that lens, you're born with, and can become quite cloudy. And when it becomes
Yes.
quite cloudy, it becomes quite difficult for you to see through. And there are certain things that you can do to sort of help you through the passage of life to sort of navigate that. But ultimately, there's a surgical requirement to sort of help with that issue. And there are
Mm.
certain things that may well manifest themselves, certain things that may well come about during the course of your life that make it more challenging for you to undertake the tasks that you would normally do, like driving, reading, that sort of thing. So simply put, it's a clouding of the lens.
Yes.
Interestingly, you talked about earlier with your journey to the optician and this kind of waveriness.
Yes.
The cataract is actually a Latin term. It actually means waterfall. And the reason
Waterfall.
waterfall, yeah,
Yes. Yes.
and the reason that is because of the way that it looks inside the eye. It's kind of a white glistening. If you leave it long enough, it has kind of a whitish appearance. And so, yeah, the Latin term for cataract literally means waterfall.
Because one of the things that you had said to me when you saw the reading, and I shared the reading to you, and because of course you're like an informal doctor at the same time for myself. When I showed it to you, you said, Silver, yeah, it's a high level really, because what you're saying to me, you said something that if anything happens and police stop me or so like that, that reading was a bit high, could affect your driving ability, isn't it?
That's the key. So I talked about those activities of daily living. One of the big things that in this part of the world we're quite fortunate to be able to do is to obviously drive and own a motor vehicle, and there are certain requirements that are required for driving. There's a visual requirement to be able to read a number plate, and this is the new number plates from around 20.5 meters, which is approximately 4 car lengths. But the approximation here of 4 car lengths is obviously quantified by a visual chart.
Yeah.
And again, from the information that you relayed to me, and I'm glad that you shared that. With the information that you relayed to me, you were quite close to the driving standard. So it makes perfect sense for those people who are driving to check their sight, to make sure that they're able to drive legally with the visual corrected with glasses, of course.
Yeah.
So regular eye tests with local opticians is key.
Yeah.
I would recommend 1 to 2 yearly reviews with an optician. A little bit sooner if you have issues, and I like if you put your glasses on there. Sooner if you have particular issues back of the
For
eye.
me, for me, it's the read, because you need the reading glasses. Like, I'm trying.
That's it.
Yeah.
Exactly. The
Yeah.
reading glasses is key for you to, obviously comfortably be able to read text,
Yes.
not struggle in that regard.
Okay, fantastic. And ladies and gentlemen, if you have any questions or so, you can put it in the chat at the same time. Do you want us to go through
Let's
the
go. Yeah,
slide?
let's do cataract. Yeah, because we touched on a couple of things there, but the I don't want to do a sort of a death by PowerPoint here. You hear that saying quite a lot, but I hope that this kind of captures some of the questions that may well be raised, and hopefully also generate some discussion this evening. So if you would like to fire some questions, as
Yeah.
Silver said there in the chat.
Sure.
So
Sure.
how do cataracts develop? Essentially, cataracts develop over the course of your lifetime. So the older that we are, the more likely you are going to develop a cataract. But there are some cardinal sort of diseases that can affect you and give rise to cataract development. Those namely seem to be in the region of sort of diabetes, if you're on steroid treatment, if you have local radiotherapy to around the eye, that can cause cataracts and allow that to progress a little bit quicker. But the other thing is UV radiation, so natural sunlight from the sun. And that's why you will, if you're out on holiday, if you're outside quite a bit, then wearing a pair of prescription sunglasses is going to be helpful. If you don't have prescription sunglasses, then at least some sunglasses to block out those unhelpful UV radiations that can bring on cataract. Family history of cataract is
I
obviously
was gonna,
there.
I was going to say, sorry, I was going to say that I can just bring in a couple of the points that you say in a personal experience, because I was in Jamaica in April, and one of the things I found out when I was driving in the evenings or in the night, the cars, they hardly dim their lights, and it
100.
was really difficult. The lights were so blind because of the advent of the cataract at the
That's
same
it.
time. So I made a decision. I'm not going to drive to Kingston or nowhere. I just keep it in Ochi. Well, of course I'm from Ochi. Just stay in Ochi.
Keep it
Yeah.
local, and you're
Local,
right.
yeah.
that's the what will you notice? It brings it on quite nicely there that from a day-to-day point of view, it's a gradual effect. It's a gradual effect that comes over the course of years rather than months. But you will notice, depending on the type of cataract that is, you might get this scattering of light that you've referred to there. We call that glare. And it can be quite off-putting when you're driving. You're quite right. And the remedy for that isn't putting on dark glasses, because quite obviously you're driving at night, right? So the whole thing is it puts people off the idea of driving. And what we want is for people to have that good quality of life. It's key that people are able to do the things that they would normally do, which is again why it's really, really important that if you do have symptoms like this, then seeking the opinion of an optometrist in the community who can sort of diagnose this problem and then refer you on appropriately to your local service. So, as I said, they developed during the probably around the age of sort of 40 plus. But the effects of cataracts generally affect people who are over sort of 60 to 70. But depending on any particular issues with regards to the causative agents I said earlier, you might get cataracts a little bit earlier in life, and it may well cause you significant bother.
So when people said to me that I'm in my early 50s, people are saying, "Oh, but you're young to get in that." But you just said a while ago that's a misconception from someone, because you're saying 40, isn't it?
It develops from early 40s, but it can affect you any course of time thereafter. For some people, it may affect them in the early 50s. Most people, it'll affect you the longer that you live. And we find the majority of our cataract surgery is performed on people 70 plus. But again, if you've got any other underlying problems, or if you were just going to have the predisposition for developing cataracts, and it depends on the type of cataract that I mentioned earlier as well, then you find that you'll need to have something done to try and help with the issue problem.
I don't know if do you want to say, why would one still need glasses for distance after the surgery?
That's a really good question. I'm going to come on to that.
Because like for me, I don't need it.
Yes. Yeah.
But go on. Tell me,
yeah,
David.
really good questions, Marina. Thank you very much for interacting. Please fire questions as we proceed. So the lens that we place inside the eye generally works for one distance. So it works for either near or distance. Remember I said at the top of the program that the lens that we are born with works for both near and distance, but over the course of your lifetime, early 40s, again, what you'll find is you might need to get a pair of glasses to try and support the inability for you to focus. And we call that a presbyopia or short-sightedness that develops because of aging. And so, as I said, as I mentioned, the lens that we place inside the eye only works for one distance. It either works for near or it works for distance. And so you need to have an additive top-up to try and help improve the correction for near. Now, for some people, just to complicate matters, for some people, we can put a lens in one eye that corrects for near and in the other eye for distance. So you then may not need a pair of reading glasses or distant glasses. But not everybody has the propensity to be able to do that or at least cope with that. And so there are certain things that we can do before the operation's planned to see whether that's something that could be essentially undertaken for that particular individual. So the majority of people will need a pair of glasses for either near or distance. And then the last thing to mention is there are some lenses that you can place inside the eye that work for a range of distances. But they are sort of premium lenses and are not something that we are able to afford at the moment to the NHS.
I found it very interesting, David, when I was doing my operation. And ladies and gentlemen, you can see me there with an X over my eye. David will explain why that X is over my eye in the future. But what was so interesting was when I heard them saying lens, and I'm saying lens, when they're doing the bits, like scalpel, whatever, lens, and I was saying lens, and then the guy told me, "Well, we actually put the lens in your eyes."
Exactly that.
That's why you come and buying it back.
Exactly that. And we'll talk about the lens in a little bit more detail a little bit later on when we talk about the development of the lens that's been placed in people's eyes. So next slide for me.
Yeah, but let's go back. What will I notice? We did clear up that, but what will you notice?
Yeah, what will you notice? Essentially, it's blurring of vision. It's the ability to see faces as sharp as previously. The world appears a little bit more dusky, a little bit more dark.
Yes.
And the glare issue is a big thing, particularly at driving at night.
Fantastic.
The inability to do the normal things you would do, reading, watching the TV, that sort of thing is
Yeah.
what would trigger it. And as I said, I keep saying during the course of this evening, it's really imperative that you go and see an optician 1 to 2 yearly just to help you through on your journey. So the
Fantastic.
next slide, I think, describes really about cataracts a little bit greater. I can't really show you on terms of the pointer here, but the lens sits behind the iris, which is the coloured part of the eye. And then you've got the pupil, which sits right in the middle there. And if you dilate the pupil and make the pupil bigger, you get more access to the lens, and you're able to see and appreciate the cataract to a greater degree. And as I said, it's that lens that becomes cloudy over time that sits inside the eye that we attempt to sort of remove. If you imagine the cataract like a grape,
Yes.
you've got the skin of the grape and you've got
Yeah.
the contents of the grape. What we do during the cataract operation is we remove the contents of the grape, we leave the skin.
Yes.
And essentially in that skin, we place the new lens inside that. So the lens is held at the front part of the eye. And that allows you then to see for either, again, focusing for near or for distance, a bit like your glasses. It's not like not like multifocal glasses or varifocal glasses, sorry.
Yeah.
This is a fixed distance, so it allows you to either see for near or for distance. So the lens that we place inside the eye is a brand new lens, and that sits with you for the rest of your life.
Wow. 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 That's awesome there. So, and
Next.
so the normal eye there, you got the cataract there. You want to go to the next one? Yeah.
Yeah, next slide for me, please.
Yeah. Okay.
So I guess the question of how, we've touched on it a little bit, but how are cataracts treated? Well, the first thing is cataract surgery may not be for everybody. Okay, some people may well have an aversion to not want to have cataract surgery.
Yes.
And I think that one of the things that we are afforded in this part of the world in the NHS is that it's, we have a condition that is treatable. And I think that the whole point of this evening is to make sure that people are aware that they can access services that would allow them to at least be have a test taken for assessment for cataract surgery. So, but what if you're not going to have a cataract operation? What sort of things can you do? Well, the lighting in the room is really helpful, irrespective. And making sure you've got adequate lighting, adequate support within your home environment to allow you to do to at least get the benefit of the environment to allow you to do the things you need to do. So it's grab rails if you need assistance. It's familiarity around the home, making sure there are no obstacles that you're going to trip over. These things are things that we should all entertain, but seldom do we think, okay, I must make sure that this box is out of the way so I don't trip over it. But particularly if you're at the latter part of life, then you need to make sure that the environment is actually as adequate as possible. The next thing to say is obviously glasses. Glasses will get you to a certain point. But past that point, surgery is really the only thing that will really help remedy this particular problem. And so glasses, having up-to-date glasses checks with your community optician, much like you would if you were going to go to a dentist every year or 6 months to a year, then you need to go see the optician regularly to make sure that you've got the bespoke prescription for you to at least make best of the world. But surgery is the mainstay of treatment. And the surgery is firstly the removal of the lens in the same sitting, an intraocular lens insertion.
Okay.
Which is a plastic lens.
Yeah, and of course, from myself moved from the glasses, went to the optician, and then that was where the recommendation was made for surgery. When the lady said, "I'm sorry, I've got to recommend you," when she made that move. Yes. Okay.
Exactly. Next slide for me. So I just wanted to go back a little bit just to talk about the history of cataract, and I find this really interesting and really fascinating. So the cataract reference really predates biblical reference. Around 2,500 years before Christ, and there's some references to cataract, and you'll see it on the next slide in a second. But don't change slides yet. But it's for Kappa. There's a Kappa statue, and it's in the Cairo, in one of the Cairo museums, that really pays reference to this. The reason I wanted to pick out this slide as well is you can see there are 3 people in this picture, and one of them has an instrument going towards the eye of another person, and this was a person called an oculist. So not an ophthalmologist. Ophthalmologist was not a thing back then.
Yes,
an oculist. And this person is introducing a stick into the eye to flick the lens out of position. And the anesthetic of choice was spitting in the eye.
Wow.
So that was the anesthetic of choice back then. You place a stick to dislodge the lens so it would fall into the back of the eye. And of course, in this instance, there was no lens that was placed inside the eye.
David, can I just stop you right there? When they were spraying that thing in my eye all a while, was that spit indirectly? But I kept spraying that little solution in my eyes. Is that?
Disclaimer here, you'd have to ask the operating surgeon, but in all seriousness, no, obviously not. But this was a procedure called couching of the lens.
Yes.
Dislodging of the lens in the eye so that it falls to the back of the eye, and that would allow clear sight. Now, this is really for people who had real white cataract, who had hand movement vision, or couldn't really see very much. And as soon as you dislodge the lens, they could see a lot more light, a lot more brighter, but it wouldn't give them reading vision. They may well be able to observe faces potentially, but the vision itself would not be great. But it would be better than it was previously. So this is a procedure called couching, and believe it or not, couching is still undertaken in some parts of the world today. The real modern thing here, though, is lenses, and we've touched on that a little while ago. And I know you've got a picture outside a really well-renowned hospital in the UK, where so St Thomas's, and St Thomas's Hospital was the home of Harold Ridley.
Yes.
Who performed the first intraocular lens implant in the world. And I'll give you the history of this, because I think it's a beautiful story, in that he was performing surgery for lots of different reasons. But one of the reasons was for little bits of plastic that was lodged in the eye. And this was from fighter pilots in World War II. And in regards to this, a medical student, or a student who was with him, or a student doctor who was with him, said, wouldn't it be a fantastic thing if you could put a lens inside the eye that would allow people to see? Because before this, they could take the lens out, but they couldn't replace the lens. Yeah. So he noticed that the lens material, or the material from Spitfire planes during World War II, when it lodged in the eye, it didn't cause any irritation, didn't cause any inflammation. To that date, they were using devices and implants in the eye, but it would cause severe reactions inside the eye. Yeah. So he figured maybe this plastic would be something I could use in the eye to help improve the sight. So that's how you develop the intraocular lens, from sheer discussion with a student doctor, medical student, or the like, and then realizing that this material didn't cause a reaction inside the eye. And that's where the first intraocular lens implant came. Now, for that particular first patient, the improvement in sight wasn't as great, but it was better than it would have needed to be, or it could have been. And they improved on that in iterations. And that's where we are today. Now we have a multitude of lenses that we can choose. Yes. The first operation was in London. Imagine that, the basis for this particular procedure. And then there's a development. Oh, go on. Sorry, Sylvan, you're going to say?
No, that's all right. Keep talking. Yeah.
And then there was the development of modern cataract machines as well. And the cataract machines themselves, you can think of as a glorified Dyson Hoover, in the sense that we break up the cataract and then we suck out the contents, as I said, of the cataract lens. And it's all done by ultrasound, high frequency ultrasound. It breaks up the cataract quite nicely.
Is that what happened to me?
That's what happened to you. So you would have.
I heard some sounds, man. And
what do you think of those sounds? Tell me what you thought. What did you?
Well, to be honest with you, while I was in the process of doing that, and I looked up and I saw some lights above me, and I saw the lights, they're getting distorted, and I hear these sounds, and then I remember the lady said to me, the doctor, before, when I was doing the consultations, he said, there's 95% chance to be okay, 5% chance to be, and I said, my days, am I going to be that 5%? Because I saw the lights starting to get distorted, and then it's like getting distorted, and I said, wow, the lights went. And then I saw it start to come back into focus and everything like that. And after that, I just heard, who is it? Professor Hammond. That was the gentleman who did it. He said, okay, that's it. I said, oh, wow, that's it, So yeah, it was very interesting, I must say. And sometimes people say, were you apprehensive? And I said, no, I was sort of eager just to get it over and done, because speaking to you, speaking to an aunt, speaking to my sister in Jamaica, she said it was the greatest thing that happened to her, because she could start seeing the potholes in Jamaica. She was able to start seeing the potholes. It was very clear. And so I was very keen on doing it. And the first day of the operation, they say you got to get somebody to go with you, and my wife was going with me, and I got a call just as we were about to enter the hospital to say, oh, something wrong with the machine, and they had to postpone it to the 23rd of the 9th as well. So yeah, it was very interesting, David, I must say.
And that, you make a good point there in regards to safety checks. Safety checks, we we take this really greatly and seriously in terms of the way that we work patients up for cataract surgery, and on the day, making sure we've got the equipment that works efficiently and effectively. And so just so people are aware, it's a very safe operation.
Yes.
We do hundreds of thousands. It's the most frequented operation in the UK. We're talking hundreds of thousands here of operations that are done prior to the pandemic and post-pandemic. So it's a very safe operation. If we move on to the next slide for me.
Okay.
So this is the statute I was talking about earlier. And if you have the quote unquote eye of faith, if you look on the picture to the right, you'll notice it's a little bit more dark in the center than in the picture, the eye on the left-hand side of the picture compared to the eye on the right. It's a little bit more whiter. And what this is truly trying to represent is from this carving that this patient had a cataract in the eye that you look on the right side. Obviously, it's the patient's left in this instance. So this is the carving, and that is in Cairo that I alluded to earlier, which is called the Caper statue, which is in the Cairo museum. Next slide.
Can I just ask before we go there? Is that a mark on the eye to say that that's the eye which is bad or so?
No, I think it's just part of the exactly your mark. Exactly.
Mark on
Did this chap have a surgical marking back in the day in Egypt? No, I think it's just part of this sculpture. But it's a good spot there, Silborn.
Okay. All right, let's go on to the next one. Yeah. Okay.
So surgical journey, and I think this is where you might have a bit of interplay with yourself here in terms of the workup. I mean, what would normally happen is, again, you would either see your optician or your GP, just with regards to any sight problems that you have. But again, just making that recommendation for regular reviews with the optician, and then they would send you to a cataract provider who would work you up for the operation, and then you'd have some form of follow up. So I don't know if you wanted to just give us a flavor of your journey for the listeners, and then we take it from there.
Yeah. For my journey, when I went to the optician and she made that referral, she wrote the letter. Then the letter had to go to the GP, and then my GP made the referral to. All of a sudden, I just got the letter from St. Thomas Hospital for me to go down there. So before the operation, as you know, I had this consultation. It was like half a day. I had to book for half a day, really, just to go through and all these different persons. I must say that St. Thomas Hospital was very sharp. It was very on time and everything like that. And they put all those sort of spit in your eyes. Sorry, not spit in your eyes. They put all those different things in your eyes, dilated so they can actually do the test. And then I do remember one of the very serious part of the discussion was when everything was done and I had to go to the doctor, a consultant. And she said to me, now, it's up to you. You can do it if you want. So I said, do you recommend me? And she said, well, it's up to you if you want. She didn't want to make that, but then I said, if I don't do it, will it get worse? And then that was a key point. She said, yes. And we recommend the left eye because that's where it is very strong. And then she said, it's okay. She gave that assurance, 95%. And one of the key thing also, just for people to know, is that the consent. There was a consent that I had to do at the same time. But the assurance was that there was 95% and 5%, not much. But always my mind was, what is this 5%? What is this 5%? 95% never really that assured me that much. But at the end of the day, it was a situation whereby I had to make a decision as to whether I'm gonna keep it with glasses or whatever like that, or just do it. And of course, not to drive or anything when I go to the hospital because those things will distort all those bits there. And it was a nice day out actually in central London that I went and I did a tour. I went to see Mary Seacole image and everything. So yeah, that was my surgical journey in the initial stage. So that's the initial stage, David. Do you want me to go on to the next bit?
So let's talk about the initial stage before we get on to the surgery then. So, some really good points there in terms of the rapid referral that essentially took place here. And, you saw the optician made it to the hospital. You were seeing a series of drops are going to be required that will dilate the pupil. So make the pupil a lot bigger, allow more light in to allow us to have a look at the cataract to a greater extent. And it's really important that you don't drive to the appointment. Because the drops can take a few hours just to wear off. So
Yeah.
you will struggle with driving, struggle with reading, particularly after having the initial consultation. And then the other thing you reflected on there was the need for signing of a consent form. Recommendations are difficult because this is what we call elective surgery. Okay, so it's not life or death, but it is going to impact you from your quality of life perspective. And
Yes.
again, life in itself is a short passage of time, relatively speaking, right? Because it is. And so what we want to do is give rise to as much enjoyment within life. And I think you probably all agree, those listening in, that sight is crucial and essential to be able to enjoy the things and see the things that you need to in life. So whilst an ophthalmologist seldom will say you need to have something done,
Yes.
we will recommend based on the findings, and the findings will be what we see, but also what you say as a patient. And again, from not to over personalize this, but from a driving standard point of view, if you are approaching the limits, then you're going to have to down tools, unfortunately, at some point if you don't embark on a cataract operation. So those are the kind of the points with regards to cataract surgery. The consent form doesn't mean that you have to have the operation either. It's consenting to potentially going on and having the operation. You can change your mind at whatever point in time you like to, but we would hope that having that
I mean, they're not
conversation.
gonna. I should have had a picture of somebody trying to pull you. No, you signed it. Come on.
Exactly that. No, we're in the NHS, Silbo, and we don't have as many people that we can get in to sort of act as pulling into theatre. But in all seriousness, I think that just wanted to make sure people are aware that it doesn't hold you to having it. It's just something that you have consented to say you would be happy having it done. And we would hope as part of that consenting process that you've got all the information at hand about the cataract operation, what it entails, what's the follow-up, what lens, or where are we going to leave you in terms of your sight? Are we going to correct you for distance? Are we going to correct you for near? All these conversations take place at that appointment, and then there's the ability to follow up that if there's any further questions that you may well have. There may well be links to a cataract nurse, for example, or direct links with the physician to allow you to feel comfortable in making that decision. Because this is a decision that obviously rests with you for the rest of your life, and it's important. But we also need to make sure you've got all that information at hand as well. So yeah, if you wanted to go on to the surgical part now, so you've made a decision. You've said yes, I'm happy for Prof Hammond to go ahead and do my left eye. What happened working up to the surgery?
Well, first of all, that was me there, with my gown and everything, getting ready, and my eyes all blurred up and everything like that, ready for the thing. And then there's a mark. I mean, the mark is there because I keep asking you this question: left eye or right eye, right or left eye? I said left, and a lady one time said, "Make sure you say left," because I guess those guys in the operating room, they're moving because I saw a few patients there. They're moving patients, and it's like 15, 20 minutes or so. So they had to be very clear. And the mark was there, and so went in there, two twos, lie down, but what was very interesting though was the eye, the bit when they sort of able to hold eyes open and doing that sort of thing. It tickly. I would say tickly with impression, feeling pressure, but not pain. If that's the right way I could say. Tickly, pressure, not pain. Yeah.
Yeah.
That's how I would is that how you would say, David? That's
Well, I
what
think it's patient's perspective of the experience, and that's why I thought it'd be really interesting to hear what you felt. And I'll comment more on that in a second. But during the operation, did it feel like 20 minutes? Did it feel like 40 minutes? Did it feel like a whole afternoon?
No, actually it didn't. Well, in the operation, you mean?
Yeah.
No, the actual operation was like, I mean, they were saying 15 minutes. I think it was about 20 minutes or just around 15, 20 minutes actually, to
But did
be
it
honest.
feel like that? Did it feel like it was a longer than that as you were lying there?
I'm going to be honest with you. No, it didn't feel long. It didn't feel that long.
There you go. Okay.
And because I was so conscious at the same time and aware,
Yeah.
and I was checking my time. Sorry, I was kidding.
Yeah, ask the surgeon, how long? What minute are we on? But no, I asked that just to so people are aware of how things may well feel. So the first part of this, and I should have mentioned really in the preoperative assessment, you made a decision to be awake for the procedure. So
Yes.
most people are awake for the procedure. That's the other thing just to say. And so they're aware of everything. They're aware of the sounds, they're aware of the light, they're aware of the noises that occur, the smell, everything they're aware
Yeah.
of. So from a smell point of view, there's nothing. There's a little drape that goes over the face.
Yes, I felt some watery thing was going in my eye at the same time.
There you go. And
Yeah,
so
yeah.
if you had a bit of hair still on, you might have had a little bit of a hair wash as well, right? So just
Okay,
because the
maybe like
washing,
the hairdresser, yeah.
that's it, right? So yeah, we use saline, which is salt water essentially, on the
Okay.
eye throughout the procedure, and you are well aware of the conversations that take place. We touched a little bit on the noises of the machine. So the
Yes.
machine sounds like a bit of a whirring noise, and some machines sound a little bit like you're in a church, and you
Yes.
can hear the church piano playing along in the background. It's a really acoustic noise, and that noise isn't just there for you as a patient, but actually it gives feedback to the surgeon, because the surgeon is looking down a microscope throughout the whole of the operation.
Get out of here. Oh, wow.
And they have 2 foot pedals. So 1 foot pedal is to control the amount of energy that's being dissipated in the eye, and the other foot pedal is to control the microscope. So as they're being passed instruments, they are holding their hand out to take instruments and give instruments away.
Yes. Yes.
But they need to be aware of how much energy they are delivering to the eye. And that's where the noises come as a feedback. So
Okay.
those noises actually do make sense to the surgeon, believe it or not.
Wow.
So there's the noise from the surgeon, and there's noise between the communication that you'll hear in terms of verbal communication to say, can you hand me the lens, or can you hand me the devices? Going back a step, you talked about a bit of pressure on the eye. That's quite normal. And there's a device that we place in and around the eye to keep the eye open throughout the operation. So that can feel very strange. But the biggest thing that we've not mentioned is pain relief. We give good amount of pain relief. Feels a bit like a stabbing pain, or a bit of a gnawing pain on the eye, just to try and keep the eye comfortable throughout the operation. And that generally works very well. And if we need to, we can top that up throughout the operation to try and keep people comfortable. Operation length, you're right, around 15 minutes, 20 minutes. I guess the worst bit I feel of the operation, and this is as a surgeon rather than as a patient, but most patients relay this back to me, is actually taking the drape off, because it's been stuck on the face for quite a while, and we don't anesthetize around the eye. So we're very gentle when we take it off, but it can just sometimes take a little bit of pressure around the eye, and it can feel a bit uncomfortable. But the operation length is very short. What could you see afterwards, Sylvan, or what couldn't you see, do you feel?
Well, because I had to, they put on this thing here, on my eye. Where is it? That bit there. Yeah. So that was the a sort of, what do you call it? Silver.
Shield.
A shield. Yeah. So therefore, I was. It's like was I cheated? But I was like looking through the little holes, and I'm saying, okay, and I could see some level of clarity, very clear at the same time through the holes, and and of course you could feel the a gritty. There was a gritty feeling. You could feel a gritty sort of,
like a gritty
yeah,
feeling in the eye,
yeah, like pebbles a bit, some small pebbles in your eyes, or so, like, or
yeah.
it's like in Jamaica when something gone in your eye, you're playing with your friends, and your mother to blow, if you feel you're impressed, you want to actually want to scratch out your eye, and
And
I guess,
that's
yeah, go on, yeah,
I was going to say, it's part of the reason we're putting the shield on, to just try and prevent you from touching the eye immediately after the operation. And you'll attest to this, but there were a series of drops that you'll be taking after the operation for a period of up to 4 weeks that can just help with the inflammation. But this inflammation is swelling inside the eye. And any discomfort, just to the surface of the eye. You use that maybe 4 times a day, depending on the types that are used, and essentially that helps you through the journey of the next few weeks. There's quite a rapid improvement in your sight over the first few days, and then it takes the first few weeks just for the lens to settle in the correct position, and the like. And then you're given sort of information from the nurses after the operation as to the things you can't do. Those tend to be things like lifting, bending, stooping, getting water into the eye immediately
Yes.
afterwards, that sort of thing. So it's a safe operation, very quick operation, give
Yes.
rise to a good improvement in sight. And for me, the other point of sort of reaching out to you today and talking this through was to talk about real innovators in the region of surgery and cataract. And one innovator, if you go to the next slide, was
Yes.
Patricia Bath. She sadly passed away in 2019, but
Yes.
she has a patent on one of the particular devices that you would place inside the eye to break the cataract up, and it's through laser. And she's very well renowned for her work, her pioneering work in the field of cataract surgery. The other big thing that she was very aware of is, and why again I'm really invested in talking to you today about cataract surgery, but also health over the period of years that I've been doing this, is that she set up community ophthalmology in her neighborhoods, her area of work, because she recognized that certain people within those areas were not getting access to the health that they should have.
Yes.
So having community ophthalmologists serve the African American communities help better improve their standard of living, their standard of quality of life. And the truest sense of community ophthalmology really started with her work as well. So really, she set her mark on ophthalmology in the US, and I just wanted to bring her work to the attention of the wider community.
And it's very interesting what you said, because just like a couple of weeks ago during the Black History Month period, we were pinpointing persons that nobody really know. Well, people know them, but they're not known, generally speaking, of their innovation and their what they're brought to the table, like Patricia E. Bath, which is of course knowledge to today. And I always say that Black History Month, which just went, that's not the end of the training on the teaching of Black history. Because this is a part of Black history myself. I mean, with yourself, David, you're a part of Black history with what you're doing. Patricia E. Bath is a part of Black history, what they're doing. And for children and for persons to recognize that they're pioneers in the world midst of it, So, and I just want to say well done to yourself as well for highlighting and coming on and to share these things as well, David. Please continue.
Absolutely no problem at all. I think it is, again, just on this last point, it's really pertinent when we have historic examples, not to sort of confine it, as you say, just to 1 month. It's history. It's a whole breadth of, and you can talk about history every day of the 365 days, 366 days this year, in regards to innovation and history. Tonight, I think she's definitely holds that value in regards to cataracts and also ophthalmology across the board because of her work within the communities that she served. And I think it's a testament that we should really talk about her work this evening. So yeah, thanks for allowing me to share. I don't know if there are any more questions in the chat that anybody had, or is there anything else that we could go over this evening? But I think
what we can talk about is the fact that the follow up now that I did. I had the follow up, which is the 26th of October, with the doctor, with the consultant, to see how it was, and they gave the bill of health to say that's good. So they say I can run up and down now. I can do all my walking and skip around. And so I said, what if my eye falls out? And the guy laughed and said, no, because of course, David, as you said before, you had to hold yourself off, restrain yourself from all these excessive things, driving as well, over the period of time. But I did go back, David, a week or so before, because and this is where you can explain. I was feeling like, what is that thing I can see at the end? I feel like, I don't know, is that right or something like that? Did they make a mistake?
yeah.
And then you sort of explain it to me, and they asked me. So if you can explain that bit there.
Yes, I can, yeah. So we are not built to have stents and things inside our heart, or we're not built to have lenses placed inside our eyes. That wasn't the dynamic that was bestowed upon us 2,500 years ago, but is today. And so what happens is when you put the lens inside the eyes, for some patients, you may well notice a little shadow or arc that affects their sight. But what happens over time is the brain adjusts to that over time.
Right.
And the position of the lens just settles down. The brain gets used to the image's quality that's coming in, which is completely different to that with respect to having their natural innate lens. So these kind of things do occur, but people generally get used to them. The other thing I was going to say for you is, Silbon, do you find yourself covering one eye, comparing it to the other, and seeing the difference in the quality of color?
Well, actually, when I'm in church sometimes and looking at the words up there, sometimes I don't know if people see me. I'm like this, you know, and looking at the different, balancing out, and of course one can see the distinctive difference in a way, as it's. I mean, filming and all these different things, and if you have a camera or so and it's distorted and it's dirty, and once you clean it off, it's just pristine, and I can see, like, is that the right word? HD look. I can see clearly, like HD, high
Yeah,
level.
yeah,
It's like a high level of sight, and I can see the distinct difference with the other one. But when they are together,
yeah.
it's they are complementing each other.
Correct.
And the
And
reason why,
that's
I don't need the glasses if I'm driving or out there. I just need the glasses, and this is a very focal glasses, which is really for both. But I only need it now for just reading. That is why I went to the optician yesterday, and they are now going to give me reading only glasses now, as well. So that's very interesting days. Yeah,
yeah,
and of
yeah,
course, the recommendation is sometime in January or so. The lady suggests that I do the other one, even though it's not as bad. But she said, just get rid of it. Just not get rid of it. Just do it. That's what
put
she
that
said.
onto
It's
the
up to
line
you.
and
Yeah.
yeah. And so that, I mean, the flavor of today's discussion was really just to sort of make sure that the listeners are aware that, we have the NHS that looks after us. We have the ability to seek opinion for health disorders, health
Yeah.
problems, and eyesight is one of those problems. We have
Mm.
opticians in the community that are able to serve us and see us. They can make recommendations of referral if needs be. And we can have your cataract operation if it's deemed necessary. If you like to have it done, it's a short procedure. You can be awake for it.
Mm.
It's very quick, relatively to other procedures. Very safe as well.
Yes.
And the recovery period is very short.
Yeah. That
Um,
is all the question that Noreen is asking. How
yeah,
long is
yeah.
it?
So in terms of the process, you're on drops for a period of 4 weeks.
Yes.
The first week is probably the most intensive of those weeks, but some people are back to work the next day, believe it or not.
Really? Okay.
For others, you might want to take a few days off to put,
Mm.
for the healing process. But the major thing here is that there are those drops that need to be put in quite regularly, 4 times a day at very minimum, depending on the drops that are given, to sort of help with that healing and the avoidance of sort of lifting, bending, stooping, straining for a few weeks. If you're a keen swimmer, for example, probably get you to stop swimming for a few weeks and find other tasks.
And your eyes with water. Don't let water get
You
in.
just don't want to get anything into the eye, correct?
So don't, as you said to me, you advise, do not watch any show that is going to make me cry. Don't watch this.
Crying is okay. Innate tears are fine. It's getting anything into the eye
Yeah.
for the first few weeks. But the wounds that we create in the eye to try and get access to the lens, they are self-sealing wounds. They heal very quickly, very
Yes.
quickly. And so there's the concern about sort of getting back to normal tasks. Again, for work is not a big thing here.
One of the things I must say though, and some people say, "Oh, the waiting list with NHS," but I never had that experience. Once the ball got going, it was just like a clockwork. They were just onto it
Yeah,
really,
I
and
don't think.
yeah.
Oh, go
Mm.
on. Sorry,
Yeah,
they're
no,
on to
no,
it.
yeah, go on, David. Yeah,
Yeah, what I was saying, I wouldn't let that be something that puts you off the idea of being referred. There are going to be some regional differences
yeah,
that I can't really comment on every region of the UK, and I don't think obviously that's not the expectation here. But I wouldn't let that put you off the idea of at least going down the line of cataract operations. And number two, there is an agency for what we call choose and book. so you can choose the place that you would like to go to
Okay.
for a particular procedure. So if you find that one area is not working for you, or one provider is not working for you, in terms of the referral, at the time you can choose somewhere else if needs be. So I wouldn't let the timing be a particular put off if that's a
Go on, David. Yeah.
I was going to say, also ultimately you've got choices that could be made in regards to where you go, but I think that the biggest thing here again is seeking counsel, seeking out a review, making sure you see an optician or your GP for this condition that is easily treatable within our communities, and referrals can be made onwards for the condition. If you're not going to go down that line, as I said earlier, then making sure you've got as much help and assistance through the aid of glasses in your environment is key. Is key and essential.
In closing off, I just wanted to make my to talk about St. Thomas Hospital there. I mean, I just had to take some pictures there. I got a doctor was taking some pictures there. It was so clean, David, I must say. I was teasing someone so you could actually eat off the ground. I say, okay, Silburn, you're the only one who'll do that. Okay, okay.
It's
But
a
there was
fantastic. It's a fantastic hospital. It's where I did part of my training as a fellow for a year, just before the pandemic. It is a place that's sits well within my heart as a place to work, to train, and as you said, very clean hospital, very nice, warming hospital. When I say warmth, I'm just saying the warmth of the staff that are there, very friendly, very open, and I'm glad you had a good experience in that facility. So that's good.
And one of the plus about doing it, ladies and gentlemen, get that time out. If you're not going into London regular, you go to Westminster, you can just do a quick tour of Waterloo, and so it's always good having that. And the cafe was very nice and everything like that, But
David, and also the other thing is just in terms of history. Mary C. Cole was right outside. She welcomes you in. She's the first lady to welcome you in, and the first lady to say, "See you later," so to speak. So,
yeah. And this first, do you know what this statue is?
Yes, that's just outside as well. It's just to the left of Mary C. Cole.
Yeah, but I didn't get the story as to what it represents.
Well, the story behind it, I'm not certain. I can't. I'm not certain of the story. But that statue is just to the left as you look at the hospital, I believe.
Yes. Well, David, unless any last word, I mean, people will watch the replay and everything. Any last word, David, especially in regards to investing in your health?
Yeah, so I mean, this is hopefully one of a few sort of discussions on health that we'll have, and I think that it's just now the time is right to sort of reignite this kind of discussion about investing in your health. We invest in a lot of things. You invest in your car, you invest in your stocks and shares. If you like Silburn, that is, not like me. If you're able to invest in your house, your car. But I think the crucial thing is investing in your health. That's going to keep you going, keep your family going. And this is, again, one of the first discussions that we'll have about health in itself. I do hope that you found it interesting, found it rewarding. If you, further advice and information, you can Google me. You can find me on a fair number of socials. But if you Google me, David Burton, ophthalmologist, I'll come up, and there's some contact information there as well. I'm more than happy to take questions outside of this platform. And I just hope that you found this interesting, eye-opening, and hopefully will give you some
definitely eye-opening.
some relief in regards to any concerns you may well have had in regards to cataract surgery in itself.
David, just one question before we go. In regards to like the Caribbean community or so, is there any sort of like we talk about prostate with Black men, is there any sort of a pathway towards persons want to move into this process?
This is again why I kind of emphasize Patricia Bath's kind of stance on this. I think there's a need to be able to promote health investment within the Black African Caribbean communities. to be able to understand conditions, to be able to make informed choice about conditions, to not shy away from making those choices, and just understand and to appreciate more, so that there are avenues that can be explored, and not to ignore them, because again, life is relatively short.
Yes.
And we need to enjoy and have that quality of life enjoyment. We don't
Yes.
want people downing tools and not driving, just because their vision, which could be corrected, needs to be corrected. And indeed, that's one of the key essential things in regards to quality of life. But there are many others. Being able to see grandkids or relatives or friends and families, being able to go out to a restaurant and be able to see the menu appropriately and not be concerned that you have to have 7 different glasses,
Yes.
kind of
Yeah,
things. Right?
I was having that issue, man. Sunglasses.
That's the thing,
I'm
right? So
confused, man.
I just want to make sure that our community is well aware that they can explore this avenue and not be concerned or worried that it's something that can't be remedied. And indeed, if you're not going to go down that line of having a cataract operation, at least being aware that you can see an optician every year or so. You can do things to try and navigate the world a lot better.
We're on the hour, David, but there's one question came in on WhatsApp actually. Is it hereditary? Should you actually with your families or so, who has it, grandparents, there's
Yeah.
someone
The answer is simply is yes. There's a family history to this. I think the biggest things we touched at right at the start, though, are other things like diabetes, steroid use, that sort of thing. But there's definitely a family history to it all. But again, Mr. Positive tonight, David Burton, Mr. Positive, it's something that can be remedied. And I don't think you look at it as a negative, look at it as a positive. If you get cataracts, I tell all my patients, if you get a cataract, it means you've lived long enough, which is a great sign.
Fantastic. That's a good one. That's a good way of looking at it. Well, David, I want to thank you so much for joining. There are other political issues and so like that we'll talk about some other time. We won't touch that. That's going to start off another thread. So listen, have a great evening, and
Thank you very much.
thank you so much, David. And if anybody reach out as well, we will hear. I'll send them to you. And I just want to say that I look forward to your book. I don't know why I say that, but I look forward for a book from you. I don't know if something is happening there.
It will come in time when I get the time. But yeah, website is davidsmburton.com. If you can find it.
David S. M. Burton. Thank you, David.
I appreciate it. Have a good night, everyone.
All the best. Thank you, David. Awesome. Peace out. Thank you. Cheers. Well, ladies and gentlemen, I want to thank you so much for joining this evening and the whole discussion regarding Let's Talk Cataract, investment in your health. And of course, David and I will look to see about other discussions and other topics in the future. Thank you for those joining on Instagram, Facebook, YouTube. And also, if you got any questions or so, please, you can send them through. And what I want to link to Dr. David Burton, you can also link me directly and I'll follow it through. So have a good evening and, take care of yourself and have a good Sunday. Thank you. Bye-bye.